So let's pick up a little bit on those two words that stood out to me, applied as well as your relationships in Washington, D.C. You spent some time there doing some important work at the FDA and at CMS. And recently, you've been quite involved in the Inflation Reduction Act, certainly poised to be one of the most revolutionary changes to the U.S. drug pricing in decades. It's going to change how Medicare Part B and D work, and hand in Part D. And uh, tell me what you think is going to be the impact that specifically on real world evidence, since CMS has said that they have quite an interest in incorporating this as essential evidence. What should our industry be preparing for methodologically, operationally, in terms of real world evidence requirements and application?
Well, CMS has certainly emphasized in these, I should say, and emphasize on my end that we're in the early days of implementation of the Inflation Reduction Act. CMS is still in the process of just issuing guidance for how they're going to implement it. They have an impossibly tight timeline for implementing many of these provisions. When we set up Medicare Part D in the Medicare Modernization Act, we had a couple of years to go from legislation to implementation. Even that was really hard to get all the details right, engage the public, and so forth. This is even more compressed than that. So there's still more guidance to come out from CMS. There also are lawsuits out there, as you know, and things are going to change before we settle down and really see how the law will have, what kind of effects the law will have, and how any undesired consequences might be addressed. So maybe we can come back to some of those issues too. But on real world evidence in particular, CMS has emphasized that they view the law as really being a means of advancing its use, in contrast to other price negotiation or regulatory price regulation approaches that other countries around the world have implemented. This is new pricing steps that come in 9 years to 13 years after a drug has been on the market. And CMS, in its initial guidance, highlighted that they're really going to be focusing first and foremost on the evidence supporting that a drug has a differential impact, meets an unmet need, works better for some patients than other treatments relative to other treatments. So comparative effectiveness is the number one thing they've emphasized out of all of the provisions in the law. And right now, what I think a lot of people, including our group, has tried to emphasize is that some more guidance is needed on what constitutes, additional comparative effectiveness value, how that translates into a higher expected maximum fair price for the drugs that are subject to negotiation. And we also think there's some things that CMS could do to make it easier for organizations to develop that evidence. For example, CMS could design coverage in the early years for a drug in a way that encourages its development, could support data sharing around tracking patients, could view this as part of their quality improvement initiatives, where on the healthcare payment side, the healthcare delivery payment side, they're trying to move to payments that are more linked to outcomes that matter to people, including patient-reported outcomes, reducing costly complications and the like. But Patty, I would emphasize that we're still in the early days of implementation. I expect CMS is going to take further steps to describe how they're going to make it easier to develop real world evidence that can count, and what they're going to do to support it in the months ahead.
Mm-hmm. And do you expect them to give the specificity that industry and policymakers need?
Well, I think government never gives you the specificity you want. FDA has a much longer history and a lot more resources to go into developing guidances about new product areas and about endpoints and things like that. I do think we're going to see more steps like that from CMS, and they've made some recent announcements about programs whereby manufacturers can come in and get some more help from CMS, but it's probably never going to be as much as people would like. And I think that's one more reason that people should view the IRA implementation as a stepwise process. If I was at CMS right now, I would focus on getting the most important basics right. Can we make sure we don't make a big mistake in the law? Can we exercise enforcement discretion where there's a price that maybe should be higher than the maximum fair price, as well as some that some prices that should be lower than where the MFP might or where the current price might be, and this is going to be something that hopefully will get clearer over time. This is another area where CMS needs more guidance. They had talked before about maybe these negotiations or discussions occurring in secret, and I can understand why that would be important for proprietary information about a drug, like how much it costs to manufacture and so forth. But for information on comparative effectiveness especially, I mean, that's information and guidelines and examples that we need to get out there so that people can be clearer about what kind of evidence is expected.